I'm John Hurst. I'm a doctor and I'm a lung specialist, consultant respiratory physician working at the Royal Free Hospital here in Camden. Although, as you know, we work very closely in Camden, so I've got very close links with the Camden Community Services who've put together these series of recordings. We're working in Camden now for about 12 years, from Lancashire originally, as you might be able to detect from my accent. And I went to medical school in Scotland, but London's my home now really, so I'm pleased to be talking to you today. So the three most important treatments for somebody living with a lung condition like COPD and bronchiectasis are not medicines. That might surprise you to hear a doctor saying that. But the three most important things are to avoid whatever it is that's causing the problem. So for many people with COPD who smoke cigarettes, that means being supported to be able to quit. And that's not an easy thing to do, but it's the single most important thing that someone can do if they're living with COPD and still smoking. The next is vaccines. Historically, 2 vaccines. We would recommend an influenza vaccine every year, and we would recommend that you have the pneumonia vaccine. Actually, the name pneumonia vaccine is terrible. It's only a vaccine against one particular kind of bacteria that can cause pneumonia, and there are many, many others. But nevertheless, it's still important, and as we're speaking now, the coronavirus vaccine too. And the third most important treatment, and I really cannot emphasise this one enough, is pulmonary rehabilitation. This exercise and education class that leaves people at the end of the class not only knowing much more about their condition and how to look after it in the best way, but also fitter. And without a doubt, those 3 are the most important things. Medicines are important too, and we'll talk about those in a moment, but let's get those 3 things right. Knowing which inhaler is right for you is really important. And there are 2 different things that we need to consider. We need to consider which medicines are in the inhaler and also which inhaler device. And generally speaking, there are 3 different types of medicine that can go into inhalers that we use for people with COPD. One of them is an anti-inflammatory. It's called an inhaled corticosteroid. And the other 2 are bronchodilators. Bronchodilators relax the muscle in the airways, making them wider, and it's easier for the air to get in and out. And we need to think as a clinical team with the person who's living with lung condition what the right combination of those is. And for many people, it's 2 of the bronchodilators together. For a good majority, for a good number of people as well, it's 2 bronchodilators with an inhaled corticosteroid. So we need to choose the right medicines. Equally importantly though is that we need to choose the right device, because it's only if someone is able to use their inhaler properly that the medicine is going to get down deep into the lung where it's effective. Different inhalers need different techniques. Broadly speaking, there are 3 different types of inhalers. Some are breath actuated. When you breathe in, they automatically detect that and release a dose of medicine. But those kind of inhalers usually require stronger breathing muscles. And so to know whether that's suitable for you, we might have to do a test of how quickly you can breathe in. It's easier sometimes to use the other sort of inhaler called pressurized metered dose inhalers. You're probably familiar with it. It's what the salbutamol, or sometimes called Ventolin, one looks like. But those are harder to take. You have to really coordinate those properly unless you were using them with a spacer. So when we're choosing a right inhaler for someone, we need to think about what that person's preferences themselves. We need to think about what combination of medicines to put in it, and we need to think about what the right device is. And it's only if we get all 3 of those things right that we're doing it properly. Like any medicine, inhalers can have side effects. And we talked earlier on about the different types of medicine that we put into inhalers. And you'll remember that there were 2 main classes, these anti-inflammatory medicines called inhaled corticosteroids and the bronchodilator medicines. If we think about the inhaled corticosteroids first, well, they can cause thinning of the skin and bruising when they're used for long periods of time. And as well as causing thinning of things that you can see, the skin, they can also be associated with thinning of the bones, something that's called osteopenia, or if it's more serious, osteoporosis. And that can be prevented with medicine, but it may be that we need to measure somebody's bone strength, their bone density, to understand whether they need to be on anything like that. There is actually an increased risk of pneumonia in people who are taking inhaled corticosteroids, and that's been quite a controversial thing. However, they are effective at reducing the risk of the other infections, these exacerbations, and so it's very, very much a balance in an individual person. And we do have clues about who they're most likely to be effective in by thinking about features of asthma, by looking at a blood test which is called eosinophils, for example, but it comes down to a balance. I think the last side effect I've mentioned in relation to inhaled steroids is that if they're not taken properly, for example with a spacer device, then they can cause deposition in the mouth and build up a fungus infection called thrush. And so for people taking inhaled steroid medications, we recommend swilling the mouth after using that medication and spitting the water out, not swallowing it. That's a good way to reduce that. In general, the bronchodilators have fewer side effects. I have asthma, and I know when I take my bronchodilator, my salbutamol, I get a little bit shaky, a little bit tremulous, and that's quite a common thing that people notice with one of the types of bronchodilator. The other type can sometimes cause a dry mouth, dry eyes, can sometimes cause some problems passing urine. That's pretty rare, I have to say. But those are some of the things that we can that we keep an eye out for, and that if you're experiencing, you might want to talk about with your clinician next time you see them. There's an important question about whether the medicine and treatments that you're on, let's be broader than medicine actually, let's say treatments, whether the treatments that you're on are the right combination of treatments for you. And that's an important part of a review appointment. And the recommendations are in the UK that everybody with COPD should be having a review with a clinician at least once a year. For people with more severe COPD, it should be more frequent than that, perhaps twice a year. Now, those reviews shouldn't happen when you're unwell. They shouldn't be happening when you're having an infection or an exacerbation, because inevitably the focus of that appointment is about getting you better and assessing whether or not you might need to have any tests done or even go into hospital. So these review appointments are appointments made when you're well, as a routine, to review how your symptoms are, how many chest infections you've had, what else is going on, what treatment you're on, whether you can use the treatment properly, if there's anything new available. And going through that process at least once a year is the best way to work out if you're still on the right treatment for you. One of the newer treatments which is available for some people with COPD now on the NHS are these things called valves, and it's worth just thinking a little bit more about those because they're new, and I think there's a bit of confusion around this as well. This is really a treatment for emphysema rather than COPD. Remember, emphysema is the idea that the air sacs are enlarged. And in some people with emphysema, that process takes place in quite a higgledy-piggledy way, such that there are areas of the lung which are much more seriously affected than others. And those areas that are very seriously affected are not contributing anything. They're not effective at getting oxygen into the body and carbon dioxide out. They're a waste of space, essentially. And so we've known for some time that if you remove those most damaged bits of lung, even though that sounds a crazy thing to do, to remove a bit of the lung, actually that's associated with less breathlessness, because it gives the rest of the lung, which is functioning more normally, more room to breathe. But clearly there's a concern in having an operation if you're someone with a serious lung condition like COPD, and so actually very few people went forward for that kind of operation, which is called volume reduction surgery, although we do still use it and it can still be effective. What's happened more recently is the idea that we can put valves into the lung, and they can be put into the lung without the need for that kind of open operation. They're put in using a flexible telescope called a bronchoscope, and they're put into the part of the airway that's feeding the damaged bit of lung. The one-way valve lets air out of the lung but not air in, and so the end result is it's almost like having that bit of lung removed, only without having a surgery. And so for some people that provides a new way of having this treatment for something that's called hyperinflation, the idea that there's too much gas trapped within the chest, treatment for hyperinflation without having to have the surgery. And we are aiming to assess everybody at the end of a pulmonary rehabilitation program to see whether that might be something that's effective. But fundamentally, what we need to know to be able to recommend that kind of treatment is what your CT scan looks like and what detailed lung function tests look like. So it almost always requires a hospital visit for tests and to see a specialist, somebody like me. Let's talk about oxygen therapy next, treatment with oxygen. The first thing I'm going to say might sound a bit surprising to you when I first say it. In general, we do not give oxygen as a treatment for breathlessness. Research shows that if you give breathless people oxygen or air, provided their oxygen levels are normal, it doesn't actually make much difference. Oxygen treatment is important though. It's important for people with more severe disease who have low level of oxygen in the blood all the time. And actually it's been shown from research many years ago now that if you do have low oxygen levels and you receive oxygen treatment, you live longer. But for it to work, that oxygen treatment needs to be given for at least 15 hours in every 24-hour period. Usually overnight, and then for some time during the day as well. But if it's less than that, it's not likely to be effective. And it really works not by doing anything to the lungs, but by protecting the heart and the cardiovascular system from that low oxygen level. So the way we look for that initially is with an oximeter, a pulse oximeter. That's a probe that sits on your finger. And if those results with you at rest, breathing air, are say 92, 93, lower than that, then we might want to think about doing an assessment to see whether oxygen therapy is something that we would recommend. And we do that by doing some more specialised blood tests, either from an artery in the wrist or from a capillary in the ear. It's important to say that in relation to oxygen, we don't give oxygen to people who continue to smoke. It's not safe. There's an explosion and there's a fire hazard. So it's a treatment for people who successfully quit, and we will always support someone to quit who wants to consider oxygen treatment. Let's talk a little bit about lung transplantation next, and who might be suitable for that. The first thing to say is that there's a very big difference between transplanting a lung and transplanting another organ, say like a kidney. If you transplant a kidney, then the transplanted kidney is deep within the body, protected by the muscle and the skin, and only supplied with a clean blood supply. But of course that's not true for the lung. The transplanted lung is exposed to the air that we breathe, and with every breath, all 18,000 of those every day, we're breathing in dust and fumes and infectious particles. And after a transplant, you have to be on powerful medicine to suppress your immune system. And so the effect of that, the immune system suppression and the transplanted lung, which is still being exposed to everything we breathe, is that the survival after a lung transplant looks very different from the survival after, say, a kidney transplant. 5 years after a lung transplant, about 50% of people, half, are still alive. Half are living longer, often much longer. Half are living less than that. So to be put forward for a lung transplant, we have to do a calculation with you which works out how burdensome your symptoms are, what effect it's having on your life, but also what we think the chances of you surviving for 5 years without a transplant are. And we can do that by using some scoring systems. They look at your body mass, in other words your weight for height, how bad your lung function is, how far you can walk, how breathless you are. And we can put that into a formula which enables us to guide whether transplantation might be something that's worthwhile considering or not. We don't do them here in London, and we generally refer from Camden to Papworth Hospital in Cambridge. It's only treatment for people who've absolutely quit smoking. And of course you otherwise need to be fit enough to go through what is obviously a major surgery. Physically fit in terms of cardiovascular system, also mentally fit, being able to be prepared for everything that's involved, not just with the transplant, but for the immune suppressing treatment that comes. So it's a really important treatment. It's a life-changing treatment for some people with advanced lung disease, but we need to think about it very carefully. There are lots of ways that people might find out about new treatments for lung diseases like COPD. The commonest is probably that the clinical team will discuss them with you if they feel it's something that you might benefit from. But often, of course, we see these things now in newspaper articles and news reports. And it's perfectly okay to ask your clinicians whether a new treatment that you see is right for you. I would really encourage you to do that and to think about new developments and to ask yourself the question, is this something I might be interested in? Of course, new treatments only come about through research, and the best research is where patients are allocated at random to a new treatment or to the existing treatment so that we can understand whether the new treatment is working. And so taking part in research, which is something that we're passionate about here in London, taking part in research is another way to hear about the latest developments and perhaps to have access to some of these treatments earlier. And again, if it's something that you're interested in, speak to your clinical teams about it and look out for adverts in the press and elsewhere. I've been asked to think about what the best and worst things you could do are if you're living with COPD. And you know, I don't know how to answer that. I've got so many things that I could say. I'm going to emphasise, of course, about smoking cessation, first and foremost, but many of you have done that already. Secondly, I'm going to emphasise the value of pulmonary rehab as that exercise and education class, not only making you fitter, but more knowledgeable about your condition. I'm going to emphasise the importance of working with your clinician to find an inhaler regime that works for you, that you're comfortable with and that you can use properly. And I'm going to emphasise, lastly, the importance of making a plan in advance of what you would do if you were going to get an exacerbation, an infection. So that if it does happen, and I hope it doesn't, but if it does, you know exactly what to do. You know who to call, you know what's going to happen. So I think that's how I'm going to end.